afternoon, and welcome to today's podcast, episode number 7 of Public Interest Podcast with your host, Jordan Cooper. Today, I am here with you with Dr. Bruce Cooper to speak about how working in the field of medicine has improved the public interest. So, Dr. Cooper, thank you for joining us today. How are you?
Fine, thank you.
So, tell me how you have, in the course of your life, through your medical career, advanced the public interest. What have you done to improve the state of the world? How do you see medicine as a means to advancing the public interest?
Well, I worked in primary care, so it's pretty much one patient at a time to improve the health of one person, which will slowly over time, multiplied millions of times, increases the health of the population as a whole.
Mm-hmm. So you see the public interest kind of as advancing the state of an individual's health one at a time. Why? So that's your career. So tell me a little bit more about why you went into the field of medicine.
Well, I went into the field of medicine because I was very interested in biology, the sciences, investigation as to what causes problems. Is very interesting, and also the health of people and interacting with people. I really enjoyed interacting with people and learning about them.
Okay, so you enjoy learning about people. Why else did you go into medicine?
Sciences, investigation, and helping the common good. Enjoyed interacting.
That's really funny. Okay, so you enjoyed interacting with people?
Interacting with people.
Yeah.
And finding out what makes them wrong and being able to find out how I can help them on an individual basis. And a lot of times in medicine, you suddenly put on that white jacket and people are able to really confide in you and tell you what really problems they're having at home, work, and then you can see how best to handle them. And usually the answer is not with medicines. It's usually people don't have anyone to talk to. So a lot of it is just listening, working with them to help solve their problems, really find out what the real issue is, which is usually not the issue that they're presenting with. And it's a lot of detective work and finding out how to help them is not so usually very obvious at all.
So what do you think really needs to be done in American policy, in American society, to address these underlying healthcare concerns that do drive patient visits, but don't actually have to do with prescribing more medicine?
Well, unfortunately, it takes more time to listen to a person than it is to write a prescription. And part of the problem is the time-limited appointments. And also, I think, on a national level, public health should be improved by making changes to our laws, by promoting the health of the public health of the population as a whole. On an individual level, I think it's helpful to have physicians be paid for outcomes rather than services, and which is really what we're after. We're after good outcomes.
So do you have any experience with quality measurement pay-for-performance programs? Have they been effective for physicians?
Yes, I mean, I worked with Kaiser Permanente, and they do promote testing and other measures that are used to promote the public good. So testing, for instance, for diabetic care, pap smear screening, colon cancer screening, immunizations. All the Kaiser is based on improving the health of the individual rather than just doing tests for test's sake. And we don't get paid for individual test taking, and you get paid regardless of whether you order tests or not.
So just for the benefits of our listening audience, there's a difference in American medicine between fee-for-service care, which basically incentivizes volume. So the more tests, the more visits, the more services provided by a physician, the more money the physician makes, versus the previous employer of Dr. Bruce Cooper is Mid-Atlantic Permanente Medical Group with Kaiser Permanente. They are what's called a HMO, which stands for Health Maintenance Organization, and they take total risk, which means they are paid a capitated rate, which again is individual members of Kaiser Permanente pay a monthly premium, and in exchange they get unlimited access to services. So therefore, it's in Kaiser Permanente's interest to not only improve health outcomes in the long term, because you want to keep costs down over the long term, but also, they want to keep costs down in the short term, but also in the long term, in order to keep costs down, you want to improve patient outcomes. So all physicians are salaried, and if they provide more care, they actually lose money instead of make more money. So the incentives are reversed in this HMO. So, Dr. Cooper, I want to get back to the topic we were talking about in terms of patients and loneliness. I think that's something that might interest our listeners. So why, what could be done? What do you think it is about American society that makes these patients seek physicians to cure loneliness? And is it any different now than when you began practicing medicine in the 70s?
I think that's human nature, is not to live alone and interact with other people. And I think it's very important for people to have friends and other people that they could interact with on a regular basis. Mm-hmm. Unfortunately, I am used as their social contact frequently. I think one thing that we're moving towards is telemedicine. Mm-hmm. I think people that are homebound will be able to communicate both audio and video with their providers and with other health personnel, which I think will help, and we're moving in that direction. Problem with a lot of electronic communication now, with future generations growing up using it, is it does tend to separate people more than bring them together. It connects them through electronic communications, but some direct interactive behavior between people suffers. So I think we're going to see over time some problems developing in human interaction between people that grew up in the electronic age, using the internet to communicate.
So telemedicine seems to be more impersonal.
Telemedicine is more impersonal than seeing someone in person, but better than just telephone contact, because you can actually see the person and interact with them through video. So I think you can see their nonverbals, you can see how they're responding, mm-hmm. They can show you things on the camera. So I think this will be somewhat of the wave of the future. They've been doing it for a while now, and not everything can be examined even with a telemedicine screen. So there is a need still to see people in person, but for people that it's very difficult to get out of the home or hard for them to travel, telemedicine is one option.
So it has its utility, but what about those individuals, especially those geriatric, which for our audience means older patients? What about those individuals who are older, they're in the home, but they're lonely, and they would have wanted to come in for that social interaction? Now they're just going to miss it, and it's becoming more of a medical interaction. I mean, on the one hand, you have Kaiser Permanente that says, look, we're here to provide medical care. We're not here to cure loneliness. On the other hand, they're not getting what they need. Is it society's responsibility to try to find socialization programs for these older Americans?
I think loneliness, depression, mental illness, all is a continuum, and I think there's a relationship between them. And I think yes, society, I think the marketplace will arrange it by people will be willing to pay money for senior centers, which is happening all over the country. Mm-hmm. I think nursing homes are going to be changing. I think senior living is going to be increasing, assisted living. I think there's a lot of changes we'll be seeing over the next 10 to 20 years. And I think a lot of it's going to be telemedicine. A lot of it will be people doing home visits. That's coming back into the forefront. It's very expensive to send a physician or maybe a mid-level practitioner to go to someone's house. Will be more reasonable, more cost-effective. That's another option.
How can America afford this new influx of long-term care demand?
I think, as you probably know, most or much of the healthcare dollar is spent on the last, few weeks,
6 months of life.
6 months of life, and even a higher percentage in the last month or two of life. I think if they got into the healthcare field earlier and set up a real bond with the healthcare practitioner and prevent some of the options, I think that would cut down on some of the expenses near the end. I'm talking about quality of life, not quantity of life. A lot of people just choose everything to be done when that may not necessarily be the best choice for that person. And yet they don't sometimes aren't given that information.
So, well, just talking about medicine as kind of a field of public service, you often think, I've often seen polls that kind of judge different professions in the United States, and politicians often rate, and actually attorneys, and from what I've seen, always tend to rate among those with the lowest approval or positive associations, which is actually one impetus for me doing this podcast on public interest. But physicians tend to rate towards the top in approval and trust and positive associations with that career. Why do you think, or can you give me anecdotes from your professional career about the relationships you've built with individual patients over time that you think might lend itself, or maybe there's something that's isn't a relationship, if you can provide an explanation as to why you think physicians do have such a job approval rating?
I've had thousands of patients over my life, and the interactions, some of them date back over 40 years. Many patients I've started seeing in the early 80s, and they become very attached to you. They trust you. And when you build up that bond, it's very, very important to have. And they intimately communicate with me now through emails, through phone calls, and in the near future, it'll be telemedicine for those that have access to it. I think that's very important to have a bond. You're almost admitted into their family. And even they'll talk to me about things that they wouldn't even talk to their spouse or their family with because of embarrassment, of fear. So it's basically an opening into their life, into their soul, and what makes them tick. And the difficulty is trying to do all that in a short, office visit, which is the big challenge. But for someone to trust you with their life, there's not much greater privilege for that and responsibility. So that is, I think, why they're held in fairly high esteem on these polls that you're quoting. It's a real privilege to be a physician and to be given the honor of being able to take care of people and have the trust that they give you to help take care of their lives and their loved ones.
And this is, again, there are many different types of physicians, but you are a primary care physician, what is known as an internist. Mm-hmm. Do you suppose it's different for other specialties?
I don't think so. It may be a little more restrictive because, obviously some physicians have very little contact with patients, radiologists, pathologists, and some of the other subspecialists. But I think anyone who deals with patients on a regular basis and interacts with them, and I think will have that same. I mean, with the primary care physician, you're responsible for taking care of the patient's entire self and all their problems, not just one specific problem. So it's probably more noted in the primary care physician's endeavor.
So you've been a PCP. You have been treating patients, and it sounds like a lot of what drives this kind of sense. Well, do you feel as though medicine is a form of public service?
Yes, I mean, I think it is. I think public service is anything serving the public good, which I think medicine does. So yes, I would say yes.
So you're advancing the public interest, and it sounds like a great deal of what you do. Obviously, you've saved lives, but one thing, it sounds like you've really built up relationships over time, and that more than anything, it seems as though the trust and the relationships that you build with your patients have been, to the patients, among the most rewarding aspects of the relationship, and that a lot of the care you provide is something other than prescribing medications.
Right. Much of what we do in internal medicine is taking care of chronic diseases, diabetes, lung disease, heart disease, all sorts of chronic medical diseases, most of which you cannot cure. It's the occasional infectious disease that you can cure. Occasionally, you're fortunate enough to pick up by screening methods cancer in its early stages and be able to cure it, whether that's a lung cancer, breast cancer, whatever. That is very satisfying. But I would say 90% of the time, it's more dealing with the chronic diseases, reassuring the patients, teaching them about taking care of themselves, stopping bad habits. I mean, a lot of the patients have problems from smoking and drinking and drug use. So a lot of it is teaching them how to take care of their life and their make healthy choices. But of course, the patients tend to listen more to the physician. So physicians are shown to, when they interact with the patient or recommend someone stop smoking, they're more effective than just doing it online, for instance.
And why do you suppose, so you mentioned a few behavioral issues that these patients have that drive negative health outcomes. Why do you suppose they have greater trust in their physician if they're hearing the same thing from their physicians they're hearing elsewhere? What kind of authority is imbued with the physician? I guess, and to that, I'm kind of getting at the sense that perhaps it's a selfless interest, that the physician is making a recommendation that is in the patient's best interest. And that is kind of an underlying assumption with any relationship between a patient and a physician. Would you say that resonates?
Yeah, I would say it's the relationship with the physician that makes the difference. And I would say, for instance, I'll give you an example of smoking. It's not Miss Smith, please stop smoking, because, I mean, she knows she shouldn't be smoking. But it's more is, how can we get you to cut down smoking? What do you think? Do you think you can cut down from a pack a day to a half a pack a day? How can we do that? So it's more working with the patient to have them make the decision, rather than just you be the authority and say, stop smoking. Because a lot of times you can warn them, oh yes, the smoke will either kill you or give you lung disease, give you other problems, which they mostly nowadays know about. But it's more that they know it's the right thing to do, but they haven't really set up a plan for it. So it's more you working with the patient for shared decision making to help them decide how to take better care of their health.
Have you ever spoken with patients about not health outcomes, but life outcomes that they would like to achieve, and how following your advice will help them achieve certain life outcomes that they desire? Like,
Sure. I've worked with that. Sometimes they have a child they want to see married, they want to see the grandchild grow up. So yes, we certainly use those as goals. But a lot of it is, again, as I emphasize, shared decision making. They have to come to the decision as to how they're going to do it. It can't be just read this booklet and stop smoking, or cut down on your drinking because you have cirrhosis. It's really they have to come to that decision on their own and how to accomplish it.
So we're coming to the end of our podcast here, and just kind of like to wrap up and ask you, as you reflect upon your career in medicine, how would you characterize the career in terms of the public interest and in terms of your desire? Is it that you were able to save lives and help people? I think, what's the greatest good that you offered through your profession to society?
Well, as I noted earlier, it's one patient at a time. So if I've seen thousands of patients over my career, I've hopefully affected thousands of people, and hopefully their circle of friends and family were affected through hopefully the improved health of my patients that I've seen in the past. So maybe if they've made choices, for instance, to stop smoking or stop drinking, maybe their friends or associates. So it does go in enlarging circles. And sometimes if so-and-so stops smoking, then her friends or her spouse would stop smoking. And then their cousins and their children wouldn't smoke. So even though I've only taken care of thousands of patients, maybe the influence spreads out to many tens of thousands. And I would hope that would be the case. And it would also affect people's decisions as to how they're going to lead their lives, and the choices they make, and the influence they have on others, and the way they vote. So hopefully I would have had a large impact on a population that would be even affect a larger group of people than I would have seen personally.
And is that basically what motivated you throughout your career on a daily basis? You get up, maybe you're on call. There's all kinds of tribulations associated with practicing medicine. Would you say that you were generally motivated to kind of have these positive externalities ripple across the community?
Well, I think on a daily basis, you are interested in the health of one patient at a time. I don't think, it's more reflecting back that I think about how it may have affected other people. But, on a day-to-day basis, it's take care of one patient at a time. Although many times you're taking care of many patients at one particular time. But usually and a lot of it, unfortunately, is crisis oriented, where you handle one patient who has a crisis and then you go on to another one who has a crisis. But most of the time you try to emphasize preventive care, healthy lifestyle, and management of chronic diseases. That would be the majority of the time that I've spent.
Thank you. Well, this has been your 7th podcast with Public Interest Podcast with your host, Jordan Cooper. I'd like to thank you for joining us once again, where we interview politicians, activists, advocates, and others who have advanced the public interest across society and across the course of their life. So thank you for joining us, and we'll look forward to having you on Public Interest Podcast next time. Take care. Bye.